Okay, so I think we will get started. I'll start with the land acknowledgement. The University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, the Tsuut'ina First Nation, and the Stoney Nakoda. And the city of Calgary is also home to the Métis Nation of Alberta. So I'm very happy to introduce Dr. Kathleen Chaput. So she is a perinatal epidemiologist and associate professor in the Department of Obstetrics and Gynecology and Community Health Sciences at the University of Calgary. Her interests lie in the intersections of perinatal mental health, substance use, and associated maternal and infant health outcomes. She uses advanced mixed methods of inquiry and analysis to address contemporary challenges in maternal and infant health research, to generate evidence for optimizing perinatal health policy and services. She also has interests in prenatal and postpartum mental health, breastfeeding, health service use, substance use in pregnancy, and infant neurodevelopment. And today she's going to be talking to us about prenatal cannabis use and maternal health in Canada.
Good morning, everybody. Well, thank you very much, Jennifer, for the introduction. And I'm really pleased to be able to have this opportunity to speak about this research. So as Jennifer mentioned, I'll be going over some results from a national prenatal cannabis use survey that we conducted a couple of years ago. That was an anonymous survey. And we have some interesting findings. It's not totally complete at this point, but I'm going to try to update with everything that we have to this point in terms of our results and analysis. So I'm going to briefly go over a bit of background with the state of the evidence around prenatal cannabis use and health outcomes, particularly some of the limitations to the published evidence to date, as well as issues around measuring prenatal cannabis use in previous studies. I'll then go into sort of the update on the results from the Canadian Anonymous Survey Project, and specifically looking at the patterns of use that we see, some associations with pregnancy outcomes, and then with broader maternal health outcomes as well. I do have a little bit as well on some of the neonatal outcomes, but the primary focus will be on maternal health. So as we know, in Canada recently, in the last 5 years, we've seen an uptick in the use of cannabis and cannabis products with the legalization of recreational cannabis use in 2018. And there's still a lot of missing information about the health implications of that use, and particularly there are specific populations that are at higher risk, and one of those is pregnant people and infants and children. So we do know that there are some risks associated with cannabis use in pregnancy. Primarily, those are identified in the neonatal population and the infants, but we don't know as much about how it impacts maternal health. The implications of that are poorly understood at the moment. We do know that pregnancy complications can have devastating immediate impact on mothers, infants, and families, as well as long-term lasting health effects for moms. So this is a really important area of study. We know also that the fetal stage of development is the most rapid and sensitive period of development in the life course to external stimuli like environmental things, infection, substance use, trauma. Those types of things can have a very large impact on development. So this is an important period of time to be examining with respect to cannabis use. We also know that the cost of healthcare and social supports for children exposed to substances in utero are substantially higher than for unexposed peers. And that includes also just around perinatal health, maternal health events as well, encompassed in that. Just in the perinatal period around delivery and birth is costing Canadians about $150 million per year in Canada, just the ones that are related to substance use. So this is an important public health problem, and also something that I think we tend to, in obstetric research, often focus on the neonatal outcomes, but I'm a big proponent of looking at both humans that are involved. Women's health is really important as well, and often gets sidelined a little bit because there's a bit of a societal expectation that motherhood is something that you suffer through. Pregnancy comes along with negative impacts. It's just part of having children, having pregnancies. So I think it's really important to be building this evidence, particularly in the area of women's health. So what do we know so far about the impacts of prenatal cannabis use? So we have some studies that have been published in the Canadian literature with either provincial or national samples looking at associations with preterm birth, stillbirth, placental abruption, small for gestational age, NICU admissions, and lower APGAR scores. These studies are primarily based on administrative data sets. So they're taking prenatal health records from just the standard notes and records that are kept for prenatal care across the country. The difficulty with this is that we have large samples, which is good, but the measurement of cannabis use is very iffy. We know for a fact that women and pregnant people, when they're in prenatal care, are unlikely to divulge their substance use without having a very open conversation with a trusted caregiver. And so we know that there's about an 85% misclassification there usually of cannabis use because the vast majority of women won't just volunteer that they're using substances. So, and the numbers I'm getting that from, we do have a few studies in various locations where they've done biological testing for different substances and then looking at what's being reported in care. And about 35 to 40% of people will actually divulge use compared to what's showing up in urine screens, for example. So that's a big issue. The other issue is that we don't have a standard prenatal assessment record for prenatal care across Canada. Every province and territory has a different one, and what they prioritize on that is different. Cannabis use doesn't make it onto very many. I think BC is the only one now who are actually, as a standard of care, supposed to be asking about cannabis use in routine care. So most of our evidence around this is using that type of data, where there's going to be a prevalence estimate of around 1 to 2% of people using cannabis, whereas when we look at actual population-based estimates, it's closer to 12% of people are consuming cannabis at least once in pregnancy. And all of our evidence at this point is still based on pre-legalization era data. So we really need to update this and kind of move on with better evidence and more current evidence. So, of course, as I mentioned, the maternal health outcomes are not as well understood. We have seen in some studies associations with anemia in pregnancy, higher rates of C-section, gestational diabetes was higher in one study in BC. Again, that's using those data sets that have some measurement issues, but still very interesting and concerning findings. And then there was another large study out of Ontario that attempted to do a broad systematic review looking at reproductive health impacts for females who use cannabis during pregnancy and preconception. And their conclusion was basically that studies are limited in number, they have small sample sizes, hampered by methodological challenges related to confounding and other potential biases. So in general, we don't have great evidence, particularly for maternal health outcomes. We have had studies that have shown a strong link between prenatal cannabis use and both mild and severe nausea and vomiting in pregnancy, which makes sense because when we look at the qualitative data, most of the people who are using it are naming nausea and vomiting as a reason for that. So they're using cannabis to try to self-medicate those symptoms of nausea and vomiting in pregnancy. But again, much remains unknown about the physical and mental health associations of prenatal cannabis use. So take-home message from this part, the evidence isn't great, and we really need to maximize the strength of evidence and the quality of the research that's happening in this area. So one of the things that I've tried to do in my program of research is to, first of all, one of the biggest missing pieces is an accurate prevalence estimate. We don't know how many people in Canada are using cannabis in pregnancy. And this sounds like a relatively easy question to answer, but it's very difficult to get a really representative sample to get a proper proportional estimate of what's going on in the population. Because we have obviously self-selection into studies. People who are more comfortable to enter a study are probably not using cannabis. The ones who are maybe less likely to volunteer for a study where they're volunteering that information. Until we can really get some surveillance data on this, where it becomes a standard data point of collection, and it's done in a way that women feel comfortable disclosing, it may be difficult for us to actually get this. However, we've tried to do an anonymous population-based survey in delivery centers across Alberta, where everyone who delivers a baby gets a little survey with their discharge paperwork, where they can fill out our survey and submit it completely anonymously. So we're trying to get a bit of a prevalence estimate, at least for the province, through that. That's underway. There's been slow uptake with it. So we're not holding out a lot of hope that that's going to give us a great answer. It really is going to take some better broad surveillance data to get an answer to that question. But that data is combined into what I'm presenting today. The majority of the data that I'm presenting today is from the Canada-wide anonymous prenatal cannabis use survey. And then I've also got a Canada-wide prospective cohort study that's just recruiting right now that will follow children and moms until age 3. And I'll give a little bit of an update on that at the end. So the first piece of the puzzle, as I mentioned, for improving the evidence is measurement of cannabis use. So my group tried to improve this because there really weren't any tools out there that had all of the domains of data collection that we needed to get an accurate picture of what's happening during pregnancy. Most of the existing cannabis use tools ask about past 3 months, lifetime use, past week, things like that. Whereas we need to know what's happening across pregnancy and actually probably what's happening each trimester in case there are changes. And we also know that the way those are worded often don't resonate with pregnant people. We knew we needed to try and get the wording correct and have some way of reducing that, the susceptibility to reporting bias that, you know, if people might feel like they're being judged or there's stigma attached, that they won't report accurately. So we did a lot of qualitative work around this, interviewing pregnant people who use cannabis, trying to get the wording of all of these things. We validated the tool that we developed against the in-depth interviews and did a retest reliability with it. And then we also did an external validation against urine THC bioassays. And we actually ended up with 100% sensitivity, 82% specificity, which was shocking to us. But I don't know that that's necessarily going to reflect what happens if we were to use this in a population study. Obviously, people who are willing to come and give a THC or a urine sample for THC testing are going to be a little more open. But we do think it has a stronger sensitivity and specificity than probably a lot of the other tools out there. So this was our first step. So this tool was part of the anonymous survey. The anonymity of this survey is really important as well because it allows people to disclose things without any risk of us linking to their health record, telling their physician, having other organizations find out about their substance use. So we did an anonymous survey. Our final sample size, that's wrong, actually. It's 2857. Not that those 30 people are going to make that much of a difference, but we did use some stratified population-based sampling across some trial sites that were basically selected for a different trial through Alberta, but because we had links in those sites already, that's where those anonymous surveys at delivery are being handed out. And then we did broad nationwide social media recruitment as well. So we collected information on prenatal cannabis use, other substance use, sociodemographic variables, maternal physical health in pregnancy, delivery outcomes, and neonatal outcomes, as well as maternal mental health. So one of the things that we battle against, even in trying to get funding for this type of research, is there are presumptions out there about what's happening with prenatal cannabis use that are often based on studies that were done in the 70s and 80s. So there's a notion that women use it for nausea and vomiting, they use it early in pregnancy, and then it drops off, that it's poor, undereducated, young minority women who are using. And this really dominates sort of the thought process around what kind of public health messaging we need, what kind of services we need to be initiating, and things like that. What we found in this study, and we expected it to be a little different, right? Because we're looking now at a legalized substance. We have quite an affluent population in Canada. There's universal health care, race, national balances of different ancestry and minority groups are different than in the US. And those all have an impact. So what we found is that the risk factors for any prenatal cannabis use included lower education, so high school or less, having an income under $60,000 a year for the household, not owning the home that they lived in, smoking cigarettes, and being under the age of 25. And these are not surprising, but what didn't come up in the Canadian population for risk factors was alcohol consumption, urban residence, ethnicity, marital status, and parity. So those are things that have been linked with it in other studies. And I think the ethnicity piece is important to keep in mind with this, as well as alcohol consumption. We actually found that among cannabis users, the alcohol consumption was lower than in non-cannabis users. So that message about alcohol is getting across to this group. And there may be some sort of, I'm going to smoke this instead of using alcohol because I think it's safer. But that's something that we need to dig into a little more. So in this study, our participant characteristics were very representative of a lot of Canadian pregnancy studies where we have a high degree of affluent population that respond. So we do know that this is not necessarily representative of all of Canada, but we have controlled for a lot of the differences in our analyses. But so nearly everybody was, more than 80% identified their ancestry as Caucasian. More than 90% were married or in a common law relationship, which is typical of pregnancy studies because the closer you are to the conception, the more likely there's a strong partnership. Over 70% owned their own home. The vast majority had higher incomes than $60,000 per year, had greater than high school education, and were over 25. So what we found in terms of some of the patterns of use, there's a broad range of how people are using cannabis in pregnancy. And this seems to be related to the reasons for use. So people who are using it recreationally seem to be using it less frequently and sort of sporadically throughout pregnancy in some cases, whereas people who are using it as medicinal, where they view it as effective for treating symptoms of illness, tend to use it more frequently. So more than 40% of people who are using cannabis in this study were doing it multiple times per day, which we found a little bit shocking. But that's the patterns that women use in pregnancy. Often they'll cut back on the amount they're using at each instance, but they use it 3, 4, or 5 times a day. So every time they're feeling a little bit nauseous, they'll take a tiny bit. And so that's important because I'll show you on the next slide that one of the greatest drivers of the overall exposure of cannabis in terms of dose is the frequency of use. So we had lots of people in the group that uses cannabis throughout pregnancy. You can see it's even more people using at least daily. So those are the people that we're probably most concerned about in terms of exposure. There are a number of people who used early in pregnancy, and then when they recognize the pregnancy, they quit. So that group is kind of separated out a little bit. Smoking is still the most common by far mode of consumption in pregnancy. We were shocked by this a little bit because in the general population, when you look in Canada, vaping is usually more common, but I think it has to do with the age demographic a little bit. We're not looking at 15 to 20-year-old men in this, and that's the majority of people who are responding to StatsCan studies, for example, are in that demographic. There are a number of people who use multiple methods. So they're smoking sometimes, they're eating sometimes. A lot of people are using topical products, creams and oils and that kind of thing. And this group is important to recognize. So this concentrate group, so people using concentrated THC products, some of them have up to 80% THC. They're very strong, and it's, that's a big exposure, even if you're just using a tiny amount. So there are some people still using those concentrated products in pregnancy. We also measured secondhand exposure, and the majority of people who are using cannabis in pregnancy also have secondhand exposure, most commonly from a partner who uses as well. So we're going to be looking into the effects of secondhand exposure. We also have quite a large proportion of people in the study who are only exposed by secondhand route. So that'll be something we're looking into in terms of associations with different outcomes as well. So this is just a little graphic that shows the total dose, estimated dose of THC throughout pregnancy. And this is, the numbers don't translate to milligrams. It's still sort of a categorical variable. But what we did is we basically calculated based on the frequency of use that was reported for each trimester individually. We calculated the number of uses that would come out to. And then the people give us their estimated dose per use, and we multiplied those to try and see roughly, do we have any kind of a, easy way to break these people down into different groups? And as you can see, there's an exponential growth as you go up with frequency of use. Even if people are using really tiny doses each time, they're quite a bit higher if they're using multiple times per day, obviously. But there's no real easy way to split this data, right? If we split it sort of with, above a certain amount, we still have a lot of people in this group here that are, falling into this category of like the frequency is high, but the dose is low. And then likewise, we have, down here, it's more uniform, but a lot of people down here still have low doses, even though the frequency is quite high. So we didn't have an easy way to split this. So what I ended up doing was some latent class analysis. So we have data from the tool on frequency of use by trimester, the dose per use estimated for each trimester or each use. And then we've also got the group that tells us about they used before pregnancy recognition and then they quit. So using those different variables, so the frequency of use in each of those categories and the estimated dose per use that they reported, we were able to separate the groups into sort of 3 exposure groups. So the first class is sort of the low to none group. This would include all the non-users, people who have used maybe once or twice in small amounts across pregnancy or individually at 1 or 2 times. Then we've got this group that used quite heavily, quite frequently before pregnancy recognition, but then quit. And these people are using quite a moderate dose of cannabis. So around the 2 to 3 on this is ordinal data. So a category of 3 for the dose per use goes to about 60 milligrams per use of THC. Yeah.
Because your mouth is showing up on the screen.
Oh, okay. I don't know if there is there a light pretty on this one? Oh, can you see it over there? There. Okay. So yeah, so this, sorry about that. I didn't realize. So this class 1 is sort of the low to no dose, no THC use at all in pregnancy, where we have that's, you know, and this is the stats program that has grouped these people. The second one is sort of the early moderate users. So we've got, you know, a high frequency of use before the pregnancy was recognized, and then people basically quit after that and it tapers off very quickly. But the dosage that they were using at that time is fairly high. And then we've got the sort of high use category where people are using very frequently throughout pregnancy, throughout all 3 trimesters. And the dose per use in that group is slightly higher than what's reported for the others as well. So now we've used these classifications as our exposure variable classification, instead of what's also limiting in a lot of the published evidence is that we have yes or no. Have you used prenatal cannabis? So there's a very big difference. Obviously, if we look at that, you remember the difference in the dosage here between someone who uses it once at a party before they know they're pregnant versus somebody who's using multiple times per day through the entire pregnancy. And some of these people were reporting using it upwards of 1 gram at a time. So you can imagine the amount, like that's a big difference to classify those 2 people in this little group up here in the same group as someone down here doesn't make sense, right? That's going to cause a misclassification bias. So we wanted to make sure that we were grouping people accordingly, but also trying to capture that nuance between the smaller exposures and the more significant exposures. So in all of the analyses, our exposure is ordinal. So we have class 1, this low use group on the left is our baseline or comparator group. And then we have the 2 higher levels of classification as well. So I was interested also to look at whether the reasons reported for use were similar in these groups or not. And so not surprisingly, we have a very high degree of medicinal use in that high use group. So the class 3, the more high and prolonged use throughout pregnancy, they're reporting that they're using it for everything, basically. More than 75% said they're using it for nausea and vomiting. Appetite, sleep is a very common one as well, and anxiety is big. What I find really interesting is that this heavy use group doesn't report recreational use as much. This group, the people who actually quit before or once they know they're pregnant, are more likely to be recreational users. So that tells us that people who at least perceive their use as medicinal are the ones that we really need to focus in on and try to do, make sure that we're informing them to make the best decisions about their use throughout pregnancy. And probably also need to include cannabis in the medicine counseling that we do in pregnancy. You know, the same way we would say, what are you taking for your depression? Maybe there's a safer option for that. What are you using to medicate your symptoms for other things? And make sure those symptoms are controlled with safer options. So then we've got an interesting thing as well. So we asked about pregnancy symptoms and symptoms of different chronic conditions prior to asking anyone in the survey about their cannabis use or the reasons for use. So I wanted to see if what they reported for their symptoms actually matched up with what they're saying they're using it for. And it's a little different. Almost everyone reports high levels of nausea and vomiting in pregnancy. So that's not a surprise that it's, 70 to 80% across all 3 classes here. There's not a lot of difference between the groups. So the fact that this group tends to report their use for multiple conditions, whereas the class 2 isn't doing that, even though their symptoms are actually kind of similar, was interesting to me. The big difference is in anxiety and depression. The levels of anxiety and depression reported in this late group are higher. And that could be that they have pre-existing mental health conditions that they're using cannabis to medicate, or it could be that cannabis use is exacerbating those conditions in pregnancy. We don't really know, but that's something that we need to sort out. So what's happening in terms of associations with health outcomes? Well, we did a big analysis, so looking at these different levels of cannabis exposure with a different sets of outcomes. So we've controlled for age, parity, socioeconomic status variables. a large group of those. And when we do that, we see higher odds of emergency C-sections in the early use group only, which is interesting. So my suspicion there is that there's something else happening with, and this could be a factor of having more early losses. It could be that the really, in the higher use, if it is causing, related to a higher risk of emergency C-sections and indications for that those could be occurring even earlier in the group that's using more heavily, and they weren't captured as well in this study. But there's also a hypothesis that this could be linked to, in the higher use group, having more miscarriages early on. But that's totally unverified, and we don't know the mechanism. We also, capturing emergency C-section as one homogeneous group is not really, clinically, we know that there's a number of different reasons that those are happening. So it would be important to dig into this further to see whether this is a chance occurrence that we're seeing in this study, or if there's something actually to it. We've also found higher odds of induction in the heavier use group, though there is sort of a trend in that early use group as well, where it wasn't significant, but in a larger sample, we might see something there. So again, controlling for age, parity, socioeconomic status. We also saw lower odds of placental concerns. So that was a group of measurements around placental abruption, placental abnormalities in pregnancy, so previa, incretia, those kinds of things. They were self-reported again, so we don't have health record linkage to verify this, but there was an association with lower odds of that in the heavy use group. And again, this could be confounded by increased early loss of pregnancy if there is a link between placental concerns. They could cause earlier losses and people wouldn't be captured in this study. We didn't see any associations with anemia, hypertensive disorders of pregnancy, gestational diabetes, or preterm labor at all. So in terms of the immediate health associations for infants, we did see significantly higher odds of small for gestational age in both groups. And there seems to be a little bit of a potentially a dose response trend there. However, that's something, of course, in a cross-sectional study, we don't have any way of telling if that's causal or not. But it is something that's probably worth looking into further. And this is something that's consistent through almost all of the infant health outcome studies with prenatal cannabis use. So it wasn't entirely surprising. We did not see any associations with birth weight itself, gestational age at delivery, NICU admission, or other fetal complications. So in terms of other maternal health outcomes, this is an interesting area. Because the high number of people that are reporting anxiety and depression as a reason for use, we weren't totally surprised by this. But we did see a higher odds of anxiety symptoms in both exposure groups. So the early quitters as well as the higher use group that used throughout pregnancy. And again, you can kind of see that seems to be a bit of a dose response relationship there. The odds ratios are quite a bit higher in that high use group. So this wasn't, again, as I said, very shocking. And it's really important that this is looked into further, because we don't have the answer as to whether prenatal cannabis use is sort of exacerbating these symptoms, or are people just starting off anxious and depressed, and this is the way that they're trying to treat those symptoms.
I'm curious if you collected data on whether women were presenting with a first pregnancy or a later pregnancy, and if that is somehow maybe contributing in terms of their health status.
Yeah, so we did collect data on which pregnancy it was. So we have parity and gravidity, and we did control for that in this analysis. There wasn't a major trend in that. We didn't see that associated with use at all in the risk factor analysis. However, we do know from the qualitative data that if someone uses a little bit in their first pregnancy and then nothing happens, they'll use more consistently in the following pregnancies. And we also know that parity is associated with mental health concerns. So it's something that we need to look into to really tease out. But in this study, when controlling for parity, we're still seeing these associations. Yeah. And these also, just to mention, when I'm talking about the anxiety and depression being associated here, again, this was, we had screening tools for these that we asked prior to talking to them about cannabis use. So this is not just the reason that they're saying they're using being associated with it. This is the actual screening for symptoms of these conditions. We saw a lot of this as well in this survey, and it was sort of a post-COVID survey. So we expected, we did see increases in prevalence of mental health conditions in pregnancy, but these are shockingly high to me. The depression usually in pregnancy is between somewhere around 11-12%. It kind of hovers around, and it was 28 in this study. Anxiety was higher. I think it was around 40% in the overall study. So that exacerbation of sort of COVID, post-COVID impacts maybe biasing this a little bit as well. It's hard to know, but we do know from this there's some strong link, at least suspected, between depression and anxiety and cannabis use in pregnancy. So where do we go next with this? So I know I've mentioned all these things that we can't be sure about this, we can't be sure about that. We don't have health records. So I also have recently launched, just last spring, we launched a giant nationwide prospective cohort study with the intention of trying to be able to study some of these little issues better. So we're starting off here, and I hope that that's visible, but I'll go over it anyway. We're currently recruiting for this study. We have, I think we've got about 2,000 people enrolled at this point. Our target sample size is somewhere around 6,000. We're recruiting through social media and prenatal and ultrasound clinics across the country. And we have also got we recruit in pregnancy, do a very in-depth pregnancy questionnaire. We'll be linking everything to maternal and infant health records. And then we've got a nested sub-study of 350 infants, mothers and infants. So half of them exposed to cannabis, half not. And in that group, we're also bringing them in to do an infant brain MRI at 3 months, psychological assessments at 3 months, and then again at 3 years with those same kids. We also have, for the whole cohort, follow-up questionnaires at 6 months, a year, 2 years, and 3 years. Since starting this, we also have a bunch of other little nested studies that have come out. And we're excited about this because we've got better measurement, we've got really good recruitment, people are interested. In this cohort right now, the prevalence of cannabis use is sitting at around 11.8%. The sample looks fairly representative so far. So we're excited about where this could go. And we will have the ability in this, because of the prospective measurement, to do a little bit more investigating into, are symptoms getting worse after use? For people who are starting without any symptoms, are we seeing those showing up with cannabis use more frequently than not? Or is it the opposite, that these are actually effective for controlling symptoms for some people? We're also doing a lot more investigating into dependence and people, separating out people who maybe are using it medicinally versus people who have a substance use disorder. And that might be contributing to use. We're going to be looking as well at the combined impacts of alcohol, smoking, and cannabis on different outcomes as well. So it's exciting, but still in its infancy. So I don't have much more information than what I've already shared. But we definitely have developed some really interesting hypotheses from the previous work to try and dig into deeper with this longer term prospective cohort. So that's it for this. I'd just like to mention the acknowledge our sponsors and funding. It's been really crucial to get a lot of funding to do a big prospective cohort study. So we do have funding from ACRI, as well as CIHR and the New Frontiers in Research Fund supporting this. And we're hopefully looking at getting another pot of funding and some support through the One Child Every Child platform for birth cohort studies, to try and get some biological samples collected as well in that nested sub-study. And at the moment, we're looking at potentially getting breast milk samples from people coming in for those visits. So we can then start to investigate a little more what's going on with breastfeeding, use during breastfeeding, and potential exposure after birth through that as well. So that's it for the presentation. So I'd be very happy to take questions. Oh, I did the blank windows.
That's very interesting. Questions from the audience?